And last, we will have Dr. Prasanna Venkatesh Ramesh's talk on iStent inject, and the MIGS Glaucoverse. Unfortunately, he couldn't be here in person. So he'll be presenting from the metaverse or Glaucoverse, as he likes to call it.
And I'm Dr. Prasanna Venkatesh Ramesh. We'll be talking about these three and taking you into the Glaucoverse DryLab as well.
So from the metaverse, Dr. Prasanna Venkatesh.
Thank you, KSOS and John sir, for giving me this
Video.
opportunity to talk on MIGS, not all the MIGS. We are going to speak separately on these three stenting devices. And I'm Dr. Prasanna Venkatesh Ramesh. We'll be talking about these three and taking you into the Glaucoverse DryLab as well. So, the three stenting devices are the iStent inject, and the inject W that you can see behind me. I started my journey in the World Glaucoma Congress in 2019, where you can see me doing the iStent as well as the hydras on top. And this is a journey that I'm still learning and I'm updating. As you can see, the WGC from Italy. So this is something which is very novel and coming into the armamentarium of glaucoma surgery. And my talk is going to be from my publication in the IGO February 2023 issue, where I'll be talking about the three stenting devices of MIGS. So the patient selection criteria, make sure you start slow and steady with a mild glaucomatous patient, POAG, then slowly move to a moderate POAG and whatnot. So make sure you select your patient with a CE ratio of 0.6 or a 0.7 or P25 millimeters, then slowly you can maybe go to the higher IOPs. So I use CDT lens, the Tansen Volt Gonio lens, as well as the iStent 6, no financial disclosure here. Let's start with iStent Generation 1, the G1 series. So, the procedural journey. So, this is the glide, the ideal implantation that one needs to do. So once you have oriented the anatomy in your mind, make sure you take the stent and tangential placement is done into the pigmented trabecular meshwork, and in this case, once the stent was placed, I was able to see a beautiful vessel perfusion in the collector channel, suggesting that it was in the right plane and the vessels are perfused. So the cheese wiring, so it has its own fair share of learning curve. So in this you can see the first attempt, second attempt, third attempt, there was a lot of cheese wiring that was happening, and only finally in the fourth attempt I was able to, understand how cheesy the trabecular meshwork was before I could place the stent. Another thing that you would have to cross in your journey is the mask. So once the stent has been placed, if there is extensive, bleeding, or you are not able to identify whether it is in the right plane or not, I think one step that I advocate for neophyte drive, take a sensitive look, it's the look of iris driving down. So when you do that, if you are able to visualize the scleral square, then you are in the right plane, and that is the plane of the pigmented trabecular meshwork. That really works well if you are not fully able to get any fast view, and if there are more of IC more pigment dispersion. So reform. So what happens in this, if you see in this particular scenario, I am trying to place my generational one stent. So when I am trying to place it, what happens here, if you see, when I am removing it, the stent is also trying to come along with the broker, or you see the stent just, hangs like a sinking ship. So again, when I'm trying to grasp it and then place it in, again when I'm trying to open the claws, when I'm opening the claws, see what happens here. Just trying to come and finally I have to take it. I have to then choose a different location, and then this time a controlled release works. And you can see a slow motion controlled release of the stent was there. And also make sure your left hand on the gonio is not compressing. Sometimes that also will cause these kind of implantation. So here again the stent tried to come out. If you can see here, it's still trying to come out, but the polarity of the coming out was counteracted with the slowness of the movement, and that made sure that all is well and well. So in advanced cases or maybe moderate cases, if you feel along with a stent, you need to do a gonectomy or with a KDD or a bag. So this is again a combined MIGS Glau. You can see combined stenting procedures followed by a KDB on either side, 2 clock hours away. Similarly, you can also use a band. So once the stent is placed, you can also combine a bent ab internominal gonectomy on either side where you can, open up the trabecula meshwork, so that if you feel an additive IOP loading is needed, combination of 2 MIGS procedures could also help in this purpose. So the iStent, the results are very promising in literature. We have also done our own study, which I'll be sharing. Another scenario, again, this is one of my the patients where a PhD was used, and the surgery was well on track. Everything went on very smooth. I had to slightly extend the rexus opening, but at the end of the IOL implantation, all was smooth. So I tilted the microscope towards me, patient said away from me, and then when I took the stent trocar, I was seeing to my surprise the stent was actually missing. So it was there in the box and I had to align and grasp it again. So see this movement, my dear. Can see the polarity of how it ripples. It's just a size of it is just like a fingerprint. So it's very, very important to take a stent that has been dropped, especially in the outside. And then once you have learned that, I think you'll be able to manage that, and then all will and well, the stent was placed very well in the angle that you can see here, and this patient is doing well. IOP is rotates with anterior imaging. Generation 2 moving to iStent inject, the G2 series, moving from a tangential implantation, now moving into an axial one. So I give a dimple and then implant the stent by a shoot or a trigger. Then after 2 clock hours, the second stent is implanted, and between the 2 implantation, you can see there is a paralimbal blanching, suggesting that the tissue is actually telling us it's in the right plane and the procedure has already started to occur. Lost but found. Definitely you will have your fair share of complications, as you can see here. Superficial implantation of a stent. What happens when you use a superviscous fluid like a Gilon flow? It just fill back. Don't panic. It's just going to stand there. So make sure you place the second stent first by giving a much bigger dimple. And once you have done that, and then try to retrieve it and place it. So in this case, I just thought I'll come out, take a breath, and then go back in. So when I was trying to come out, right, I failed to close the trocar, and I again lost it. You can see again a heart in the mouth moment where I lost the stent again. So to my luck, it was just there, the TECO wound. So the TECO message was always you close your trocar when you take the stent out. So I had to go back and take the stent, then again went in and then implanted it. So all is well and well. So these are some of the videos which I didn't have much of learning videos during the time when I started. To the benefit of neophytes, I felt these simple tips and tricks will be really helpful. So PECO iStent analysis, I hope.
So due to shortage of time, I'll skip over this part, and we can take any questions. So this is about the analysis and all that. And the Glaucoverse is basically a few apps which Dr. Prasanna has, which you can download on the Play Store. So I'll give you the links for the apps later. And